Strong work. Now let's organize your information to include an assessment and plan before presenting to the preceptor. Your interview and physical exam were smooth. I loved your language and your patient education piece. Great call to action to follow up on the patient's nutrition. Holistic care is vital, and as we know, everything is interconnected. Something to keep in mind is to confirm the patient's age, their name, and gender preference. It kind of sets the expectation for more inclusive care. And you were very thorough. Things you didn't ask, but I would like you to consider is asking about sick contacts or household members with similar symptoms. It might allude to a more infectious etiology. What about family history? Any history of bladder, stomach, liver, or gallbladder cancers? Last colonoscopy, get an immunization, last PCP visit. All of these are important. When a patient tells you they recently had hernia surgery, ask what kind, when, and if there were any complications. On physical exam, it's also good to routinely check the heart and the lungs, and you can do a fecal occult blood test if you are concerned about a bleed, like a gastric ulcer bleed. All right, so let me spit out a presentation to you as an example based on your excellent visit, and then we can talk about it. Miss Vaughn is a middle-aged female with history of hyperlipidemia, presenting with 5 days of worsening right upper quadrant pain. Onset occurred after overeating at a Las Vegas buffet that started as sharp, crampy, with radiation to her right back shoulder, scaled as a 4 out of 10. Today, she rates her pain as a 7, with intermittent episodes occurring more frequently every 1 to 2 hours, lasting for 15 to 20 minutes. Pain's aggravated by meals, and she's tried Tums, which offered minimal alleviation. Associated symptoms is nausea, vomiting, malaise, decreased appetite, and subjective fevers. She's never felt these symptoms before, and she denies hematemesis, constipation, diarrhea, bloating, weight changes, and no bruising or rashes in the area. She takes 20 milligrams of Lipitor daily, Tums and Advil, for her infrequent headaches, and she's allergic to sulfa drugs, which causes rashes. She reports recent hernia surgery, otherwise no hospitalizations or injuries. She works as an insurance agent and missed work yesterday due to her pain. She lives at home with her husband in an apartment in Denver, and diet consists of fast food and frozen meals, with 4 to 5 cups of daily caffeine. She endorses daily physical activity and exercise, but the pain's been waking her up at night. She's still able to go back to sleep, getting 8 hours of sleep. She's a never tobacco user, drinks 2 glasses of bourbon every weekend, denies IV or illicit drug use. Objectively, BP's 136 over 86, pulse 74, respiratory rate 12, and she had a fever today of 101.6. On physical exam, she was non-toxic appearing, no acute distress, with friendly affect and mood. She was not jaundiced. Abdominal exam was pertinent for no rigid belly, no guarding, no hepatosplenomegaly, but she did have present bowel sounds. Right upper quadrant tenderness was reproduced upon palpation with a positive Murphy's and Rosving's. To recap, this is Miss Vaughn, a something-year-old female with past medical history of hypercholesteremia, here for worsening right upper quadrant pain, ongoing 5 days, associated with nausea and vomiting. Highest on my differential, cholecystitis, based on her low-grade fever, sharp, intermittent, postprandial pain pattern with radiation to her right shoulder blade. Other most likely considerations based on that pain, presentation, and postprandial trigger include cholangitis, GERD, and pancreatitis. The positive Rosving sign and fever warrants rollout of early appendicitis, and labs and imaging can help guide if hepatitis or renal calculus should be investigated. So to start, her first problem for our plan, worsening and intermittent right upper quadrant pain. I'd like to order CBC with DIF, ProCal, looking for leukocytosis and neutrophilia, signs of bacterial infection. CMP helps us see electrolyte, kidney, and liver enzyme status, and let's also do alk-phos for duct involvement. I'd like to get a lipase level. If elevated, we're more concerned for pancreatic involvement. If possible, to do in office, a right upper quadrant ultrasound is the best initial test for cholecystitis or cholelithiasis. We can see stones, gallbladder edema, pericholecystic fluid, and also check the kidney and the liver. It's easy, fast, low risk to the patient, and gives us a lot of information in narrowing the differential. If it's positive for cholecystitis, laparoscopic cholecystectomy and empiric antibiotic treatment is indicated. For her pain and an antipyretic, let's schedule Tylenol and ibuprofen. And diet, I suggest a PO clear liquids. If surgery is indicated, then transition to NPO. I'll follow up as soon as labs come back or within 2 days. And she's been instructed to go to the ED if worsening or new onset of symptoms, which might indicate the need for emergent surgery. For nausea and vomiting, we gave her 4 milligrams of Zofran, PRN, and continued PO clears. The next problem are her chronic conditions such as hypercholesteremia, continue home Lipitor, and PCP follow-up for management. And poor nutrition, looks like patient is in the preparation stage of behavior change, so we scheduled an additional appointment with the office dietitian to go over counseling and education next month. We are dispoing her home pending labs and imaging, and keeping her diet PO clears with the possibility of transition to NPO and scripts for pain and nausea.